Right now, what's your unmet need?
A treatment that is a cure, in effect.
A cure?
Yes.
So a genetic treatment?
A genetic cure.
Somebody who's not making factor VIII, with this treatment now, boom, factor VIII is there. We're done. Go home.
Right.
Put you out of business.
Pretty much. I would love to be out of business. There are plenty of other diseases to work on.
What's your best guess? Going down the line?
I would say there will be a gene therapy product available in 2 to 3 years.
Stop.
Yes.
2 to 3
years.
Yes. You just keep stopping me. There's progress going on. Yeah, well, it's amazing. This is quantum leaps.
Yes.
This is disruption upon disruption upon disruption.
Yes.
Let's get rid of hemophilia.
Right.
And you're telling me 2 to 3 years, boom, we can.
Right.
How certain are you?
I'm pretty certain. The certainty really is that I know there will be drugs that will be approved, viruses that will be approved. That is a certainty. How long they last, side effects from them, could they cause cancer? What are they doing? Those are all other issues. Now, they may be approved in 2 or 3 years. Whether patients will avail themselves to those drugs is a totally different question.
What are the unmet needs?
Yeah, so we've only been talking about hemophilia A, right? So we haven't talked about hemophilia B, right? I mean, they're looking at the hemophilia patients and saying, I know that they have a higher rate of inhibitors, but now they have options that the hemophilia B community doesn't have. And so there is a new drug called concizumab, another AB, and that's in clinical trials that will work both in hemophilia A and B. So that's a significant unmet need. Those patients with hemophilia B and inhibitors are incredibly difficult to treat. The options aren't good, and so they need a therapy that works the same as on the A side. But thankfully, the companies are seeing that and saying, we're going to answer that. But gene therapy there's success stories on both sides, which is great.
That's exciting.
Yeah, and then there's the chronic pain issues, right? We're talking about young children. We have these older adults that have a lot of issues, and just like in the community with opiates, we have to do a better job of handling pain because we can't use things like NSAIDs in our hemophiliacs safely.
What about patients? We've talked about this from the physician side. What are the patients' concerns that we probably haven't met?
Yeah, so I give a lot of talks at patient advocacy meetings, and for me it's helpful because people will tell you what they think about it, right? I mean, and so I go to those meetings and I see what those unmet needs are, and the inhibitor management is one big thing that's addressing, and obviously getting gene therapy available, but coverage as well. I mean, these patients used to have their lifetime caps. They were meeting this before they became adults. You see these T-shirts where they say, I'm not pre-existing, I'm existing.
Nah.
And so, we need to make sure we protect those patients because they have a pre-existing condition, and we need to make sure they're covered and that we're not forgetting about them as soon as they turn 18.
It seems to me that for somebody born with this genetic issue, going forward, let's say born in the next 5 years, the landscape's completely transformed.
Absolutely.
You're dealing with quality of life issues on people who've been getting older treatments and have the consequences of incomplete treatment.
That's correct. So the grandfathers of any child that's born from now on, the grandparents will have borne the brunt of the technology that was available at their time, including the problems of hepatitis and HIV and all that. Their grandchildren now will probably live at an age where hopefully we won't see inhibitors. The treatment paradigm is much easier, and patients won't have any major significant bleeding episodes, and then eventually lead to a cure down the line.
Yeah.
If you have any last thoughts to share with our audience, what would that be?
Yeah, I mean, I think it's an exciting time. We don't want to get complacent because we have these new therapies. We still need to address the issues that are in front of us about inhibitor eradication, looking at therapies, making sure we don't develop inhibitors in these new patients. And we need to do a better job. And so I think, it's important that these patients still follow up with their hemophilia treatment centers, and we still are diligent in addressing all these issues.
Just been great talking to you. I want to thank all of you for joining us as well. I hope you found this MD Magazine Peer Exchange discussion to be useful and informative. I'm Dr. Peter Salgo, and I'll see you next time.